In the trauma bay, a patient's sudden instability often tracks back to a source smaller than a physical injury, a systemic electrolyte crisis. The margin between survival and systemic collapse frequently hinges on microscopic fluctuations in serum electrolytes. Three primary ions govern this equilibrium. Potassium regulates the heart's electrical system, sodium dictates fluid balance and neurology, and calcium controls neuromuscular activity. This table identifies the precise physiological baselines required for stability. Potassium must remain between 3.5 and 5 milliequivalents per liter. Sodium operates between 135 and 145, and calcium is held within its own rigid parameters. In a critical care setting, the protocol follows a specific hierarchy. Stabilize the patient first, then correct the deficit. The immediate priority is neutralizing the threat of cardiac or neurological collapse. Clinical success depends on treating the physiological threat rather than merely chasing a laboratory value. Potassium serves as the master regulator of the myocardial electrical grid, specifically controlling cardiac repolarization. When serum levels exceed 5.0 milliequivalents per liter, the patient enters hyperkalemia. This buildup is common in acute renal failure, where the kidneys stop filtering, and in rhabdomyolysis, where massive muscle destruction dumps intracellular potassium into circulation. This morphing ECG illustrates hyperkalemia. T waves peak into a tented shape, and the QRS complex widens, signaling impending arrhythmias. The first step is an intravenous push of 10% calcium gluconate. It stabilizes the myocardial membrane, preventing cardiac arrest. Next, clinicians shift potassium back into the cells, using an infusion of regular insulin and dextrose. Only after the heart is protected do we remove the excess ion via binding agents like KXLA or emergency hemodialysis. Hypokalemia, serum levels below 3.5, presents an opposite danger. This is frequently driven by massive gastrointestinal losses or the use of loop diuretics that flush potassium out through the urinary tract. The ECG for hypokalemia shows a characteristic flattening of the T wave, measurable as T segment depression, and the appearance of a prominent pathological U wave. Correcting this deficit requires extreme caution. Intravenous potassium must be infused slowly via a pump. Administering it as a rapid bolus is an immediate lethal injection. Because potassium directly dictates the heart's electrical conduction, failure to recognize these patterns leads directly to fatal arrhythmias. Sodium disorders are essentially disorders of water balance, and their primary symptoms manifest in the central nervous system. In hyponatremia, levels below 135, low extracellular sodium forces water into cells, causing neurons to swell dangerously. Conversely, hypernatremia, above 145, acts as a vacuum. High sodium strips water from brain tissue, causing cells to shrink. Both extremes disrupt consciousness. Patients present with lethargy and confusion, progressing to seizures and coma. Correction of these states is governed by a strict metabolic limit. The shift back to normal must be calculated and intentionally gradual. Correcting a sodium deficit too aggressively can cause osmotic demyelination syndrome, where rapid fluid shifts destroy the protective myelin around brainstem nerves. When managing sodium, the clinical priority is preventing irreversible structural brain damage through controlled, slow fluid adjustments. Calcium acts as the threshold regulator for neuromuscular excitability, determining how easily a nerve or muscle cell will fire. Hypocalcemia, low serum calcium, lowers the firing threshold. This hypersensitizes the nerves, resulting in muscle tetany and hyperreflexia. You can identify this via Trevostek sign. Tapping the facial nerve anterior to the ear triggers an immediate involuntary twitch of the facial muscles. Trousseau sign is another indicator. Inflating a blood pressure cuff above the systolic pressure for 3 minutes induces a visible carpopedal spasm in the hand. Hypercalcemia, often caused by malignancy, follows the bones, stones, groans, and psychiatric overtones pattern. Bone pain, renal calculi, abdominal constipation, and apathy or depression. On an ECG, hypercalcemia manifests as a shortened QT interval. Management begins with aggressive hydration using normal saline to encourage the kidneys to flush out the excess calcium. These visible bedside signs provide a direct window into the patient's internal ionic state. These ionic shifts are closely linked to the body's acid-base equilibrium. During systemic acidosis, the body drives hydrogen ions into cells to buffer the blood. To maintain electrical neutrality, the cell must displace its own positive ions, displacing intracellular potassium directly into the bloodstream. Medications often serve as the trigger. ACE inhibitors and diuretics alter how the kidneys process these ions, frequently inducing iatrogenic crises. This is particularly critical for patients on peritoneal dialysis. Because they lack normal renal filtration, they are entirely dependent on external fluid exchange, making them highly susceptible to rapid ionic fluctuations. Effective management requires anticipating how pharmacological changes and pH shifts will alter the patient's ionic baseline. A dialysis patient arrives in the ER with profound weakness, a heart rate of 40, and a widening QRS on the monitor. This is a hyperkalemic emergency. Before waiting for the lab results, you must administer intravenous calcium gluconate to stabilize the heart. Avoid the lethal pitfalls of electrolyte care. First, never give intravenous potassium as a rapid bolus. Second, never correct sodium imbalances faster than the established clinical guidelines. And third, do not delay stabilizing treatment while waiting for a laboratory printout if the ECG is already showing pathological changes. Stabilize the patient, the symptoms, and the cardiac monitor. The laboratory value is a guide, but the physiological threat is the actual target.